Chief Medical Director of Zamindar Microsurgical Eye Center, Bangalore. Dr. Zamindar is a proficient phacoemulsification cataract surgeon. Both her hospitals are NABH accredited hospital. Zamindar Microsurgical Eye Center is WASH certified for COVID safety. WASH stands for Workplace Assessment for Safety and Hygiene. Now over to you, Dr. Samina ma'am.
Thank you, Shweta, for that kind introduction. And hello, everybody. I hope you all are enjoying this webinar as much as what I'm enjoying. Thank you, Dr. Nirmal, for making your talk so informative. And thank you, Professor Chang. It was really wonderful listening to the safety measures you take in your country. We really have learned a lot from them. So thank you so much. Dr. Nirmal, there is a question for you before I go to my panel discussion. And that is Dr. Smitesh Shah from Mumbai feels that he's been practicing in Mumbai for 25 years. And he has an experience of working with AHU and without AHU with the same infection rates. We would like to ask him maybe that what is his experience. But another thing what he wants to ask is that to maintain the humidity with AHU in a city like Mumbai becomes very difficult. So do you have any answer for that, Dr. Nirmal? After you clear this question, I'll go to my panel discussion. Thank you so much.
Yeah. Thank you, Samina. I thought I'll answer this directly rather than answering in the question and answer. See, there are important aspects in infection control. So one, as I said earlier, prevention is better than doing all sort of other gimmicks. One of them is engineering controls, and engineering controls maintains three important parameters. So one among them is the air filtration, the quality of the air. Second is to maintain humidity. The air handling units really help us to maintain the level of humidity. And remember, all the air handling units are designed as per the requirement of the local conditions. In coastal areas, as you are already aware, the humidity will be very high. I come from Chennai, where the humidity sometimes goes up to 100%. But for the comfort of our being, the air conditioners helps us to maintain the humidity to around 50 to 60%. The ideal relative humidity percentage is 55% plus or minus 5. So if you have a good air handling unit with designed dehumidifier, you can really maintain the humidity at the comfort level for easy working of the team. What happens if you don't have this dehumidifiers? Right, so the humidity will not be in a comfortable level. We'll be sweating a lot, or there will be extremes of temperature. So for conducive working atmosphere, we may not be in a proper shape. Once we sweat a lot in a closed atmosphere, so there is the risk of we becoming uncomfortable. And if one of our staff or a member is already infected, so this gets circulated into the system. If it is not removed properly, so that's what the air handling units does. It takes away this air and keeps on pushing fresh air into the system. And this dilutes and also reduces the bugs in circulation. Okay, so humidity, maintaining the humidity not only helps in infection control, but also reduces the risk of fires in the theater. So we use many equipments, and all of these are semiconductor or conductor machines. When there is a moisture or high level of humidity, there can be risk of fire. So having a good AHU with humidity control really reduces the risk of fire. The third aspect is corrosion, right? In coastal areas, the corrosion is very, very high, right? So the tubings carrying the seawater or salt water or even the exposed areas can get corroded. If you want to see that, you can go to the coastal areas of any city like Mumbai or Chennai, see the corrosion of the buildings and exposed the steel structure near the area. To strengthen that, we need to maintain the humidity in the internal surfaces, right? So this again is an important parameter. So what happens when there is, I think I've already added a slide So when you don't maintain a humidity, the extremes can really help in mold formation, fungus and bacteria. So mold formation, if you go to coastal area libraries, you can see the smell of the mold in the open books because the humidity is not maintained. So if you don't maintain a proper humidity, and if there is extreme humidity, mold can form within 2 days. In record 2 days, you can smell the mold. On the other hand, if you have a good dehumidifier system and maintain the humidity to around 50 levels, so this mold growth will not be there and it will be a safer theater. And very often you see molds growing in the, when you go back the root cause analysis of cluster endophthalmitis, is either Pseudomonas or it is some fungal infection, right? The growth, where does it come from? It comes from the surfaces. And how does it reach them? Through the pores in the container, the PVC container or bottle container. So basically, prevention starts from at source, right? So maintaining a humidity, maintaining a good filtered air, and also cleaning the surfaces, disinfection really helps us in reducing the infection rate. So there can be comparison in ophthalmic theaters or dermatology theaters, because our usage, our exposure of the internal structure is very, very small now. With the advent of valvular phaco incisions, and it's already safe. We are close to around 98 to 99%. So comparing this with only on the infection rate aspect is not really good. So we had a long discussion with the ISHRAE, Indian compatriot of the ASHRAE standard, which devised the HVAC for healthcare facility worldwide, right? So they say India is a wide country, fluctuating humidity, temperature, and the external cleanliness. For this kind of situation, we need to have good heating, ventilation, air conditioning system with good laminar ventilating system for maintaining not only air quality, but also maintaining the safety of our operation theaters. Reduce the risk to the people, reduce the risk of infection, reduce the risk of fire, reduce the risk of mold formation, so that at the end of the day, we have comfortable working environment in the theater and safe for our patients.
Thank you, Dr. Nirmal. I think this answers the question completely. I hope Dr. Shah has got his answer. Before we start the panel discussion, I would like to request Ms. Shweta to introduce the exemplary panelists who are going to answer some wonderful questions. Shweta, can you please introduce the panel? Then I'll go ahead with the panel discussion.
Sure, ma'am. So today for the panel discussion, we have Dr. D. Chandrasekar, sir, Dr. Nutan Shah, Dr. Shailbala Patil, Dr. Supriya Mushriff, and Dr. B.K. Gupta. So Dr. Chandrasekar, sir, is a consultant and NABH coordinator at Arvind Eye Hospital, Coimbatore. Dr. Nutan Shah is a medical director at Dr. Nutan Shah Eye Hospital. Dr. Shailbala Patil is a professor and HOD of Department of Ophthalmology, PIMS, Uran. Dr. Supriya Mushriff is Associate Professor, Index Medical College, Indore, Consultant Ophthalmologist, Retina Specialty Hospital, Indore. Dr. B.K. Gupta is a partner and consultant for Gupta Eye Hospital, LLP, Panipat. Now over to you, Dr. Samina, ma'am.
Thank you, Ms. Shweta. So this panel, we have some very pertinent questions about management of medication, about consents and communication. And the first question goes to Dr. Supriya Mushriff. Dr. Supriya, would you like to tell us that if you're using, reusing single-use devices in your hospital, what are the precautions you're taking, and do you have a protocol for that? This question is about reuse of single-use devices, which we do quite often in ophthalmology. Over to you, Dr. Supriya.
I just wanted to tell everyone there is a lot of confusion between single-use devices and disposables. Basically, single-use devices are mostly, as per manufacturer, it has to be disposed. But in our country, like India, where cost strains are there, it's been reused. Whereas internationally, there are some all points are there how to reuse and reprocess, or they use third party to reuse and reprocess. While in India, various hospitals are using this reuse policy, in-house policy. There is no criteria by government or by any institution it's given. So every hospital is having their own individual in-house policy for and to reuse any product like surgery, like just for example, a disposable gloves for that matter. So in our hospitals, to decrease OT waste and to decrease OT cost, where very poor patients are getting operated, we use gloves, but we are properly sterilizing it before going to next surgery. So this is a very small example I am giving, where how we should reuse a single-use devices, whereas it is written on the gloves that it should be disposed after one use. But we can reuse by proper sterilizing it, at least for 3 cases. And we have seen there is no any case of endophthalmitis as of now, where we are using at least 3 times, in 3 cases we are using single surgical this gloves. I'm just giving an example.
Dr. Supriya, is there anything you would want to add to this? Yeah. Anybody in the panel would like to add something to what Dr. Supriya has mentioned about reuse of single-use devices? I see Dr. Gupta and Dr. Nutan raising. Dr. Nutan first, yes.
If we have to reuse, means there is no choice. Maybe say a cassette in a phaco machine, which would be a very costly thing. Then before reusing or sterilization, most important part is the cleaning, and there is no substitute for it. If we have to reuse, we have to see the safety angle first and only then go for a reuse. Just a point that I wanted to highlight. Cleaning is equally important and sterilization, of course, is there.
Okay.
Thank you.
Yeah. Dr. Supriya, you've raised your hand. Please tell us.
Yes, and there are a list of things which any institution or any hospital should have before using any single-use device. So I would recommend any hospital or any organization who are using single-use device, they should have a written policy, in-house policy, to how to reprocess any device, whether it's gloves, whether it's phaco cassette, or they should have their in-house policy and they should follow it strictly. Whether you have to change that phaco cassette after 4 surgeries or 5 surgeries, what is your policy? That should be written in properly written. Also, hospital should have a mechanism by which reporting of potential adverse events should be there. If in case any adverse event like endophthalmitis, if occurs, there should be proper reporting of it. And also, while making all the policies of reprocessing and reusing of SUDs, all the legal and ethical concerns should be taken in consideration while making any policies. Also, any hospital should have a protocol for ensuring adequate functionality and sterilization of devices before its reuse. And also, I would like to add, a hospital should have a policy for taking consent also with patient. Means we should not, ethically it's wrong if you are using any single-use device in a patient without even telling them. So we should have a policy for proper taking consent to the patient that some things will be reused in your surgery, and proper there should be policy. This will for showing the willingness of the patient, and it should be properly written if patients show willingness. And also, if hospitals should conduct regular audit at particular interval to report any suspected cross-infection or any breakdown if any single-use device is used in any surgery. And if a hospital is having their own reprocessing unit, that reprocessing unit should be properly means ISO certified or should be registered with any regulatory authority, means licensing authority. If hospital is having any in-house like reprocessing unit, and there should be a authority, a person should be placed at higher authority who should monitor how the reprocessing is going on and how sterilization is going on. and he will be the person who will be in charge to run, who will say if any adverse event occurs, he will immediately tell everyone. So there should be an authority. I think this all point should be there in a hospital or organization who are using SUDs.
Absolutely. Thank you, Dr. Supriya. So just to summarize what you said, that there should be a protocol in place. There should be a standard operating procedure for reuse of single-use devices. There should be a policy on it. And you said hire a person. That means if you have a hospital infection control committee, the chairman of the committee should be aware about this whole thing. And if you have an HIC nurse, if there is any adverse events, the HIC nurse should be able to communicate this information to the entire team about this, and how many reuses are possible, how many reuse you will do. And after every reuse, and obviously, like Dr. Nutan said, cleaning and sterilization is must. And there should be a policy in which you should be checking whether the particular thing is fit to be reused. So a check on it, and a system, who will check it, how it will be checked, when it will be checked. All these questions should be answered in your SOP, and a line definitely to be entered in the consent that in your surgery or your procedure, there might be devices which will be used, which are reused and which are single-use devices. So this particular line has to be added in your consent for the surgery or the procedure. Dr. Supriya, thank you very much. Dr. Gupta, would you like to add something to what has already been discussed?
Dr. Supriya has already explained everything.
Excellent.
Nothing. She's already covered.
Much. Thanks a lot. And just so that we are, because there are a lot of participants listening to the talk, we would not advise using of the same gloves for 2 patients. So that's definitely not something what we would recommend. So using the same glove for the same patient was an example given by Dr. Supriya, but as a team over here, we would not recommend for ophthalmic surgeries. We go over to the next question.
I was just giving a wrong example. I should have taken an example of a phaco cassette in that way.
Yeah, thank you so much. Thanks a lot. Thanks for clarifying that. We go over to Dr. B.K. Gupta for his question. Dr. Gupta, there are a lot of high-risk drugs what we use in ophthalmic centers. There are narcotics sometimes what we need to use in our surgeries for anesthesia. Can you please tell us that what is the kind of protocol for use of high risk and narcotic drugs in our hospitals, and if there is any consent or any such particular protocol for that, please let us know.
Thank you, madam. High risk drugs, whenever a new eye surgeon listens this word, he says, I'm not using any high risk drugs, I'm simply using the drops. And same as with me also. In fact, we the eye surgeons are also using a number of high risk drugs. So it's a misnomer when eye surgeon thinks they are not using any high risk drugs. Just to summarize, there's a list: a pinch, anti-infective, potassium, insulin, narcotics, chemotherapeutics, heparin, and others. This is a long list of high risk drugs. And among us, 3 or 4 drugs are commonly used by the eye surgeons at every level. So eye surgeon cannot say, I'm not using the high risk drug. He should be well versed with the protocols concerned with the high risk drugs. So there are the extra precautions regarding the high risk drugs, but these drugs should be kept under the lock and key, and preferably by the double lock and key. And whenever a doctor prescribes, he should be doubly sure that he is prescribing a high risk drugs. Similarly, the nursing staff, whenever we ask to the assessment, what do you do extra for the high risk drugs, nursing staff usually fails. So nursing staff has to be doubly sure that she is using the high risk drug. She should read the prescription twice. She should read the drug name and doses and mode of administration twice before giving the administration to the patient, because the safety margin is very less in these high risk drugs. And then how to dispose the leftover or empty vial, that nursing staff is to follow the protocols of the hospitals, how to dispose of the leftovers. These are some points regarding the high risk drugs. And then look, LASA drugs also come under the risk of high risk drugs, because there are more chances of error in LASA drugs. And then second in question was the narcotic drugs and psychotropic substances. There were very strict rules, but which have been liberalized in 2014 by adding a list of essential narcotic drugs. There are 6 drugs which have been added in the essential narcotic drugs, that is codeine, hydrocodone, oxycodone, fentanyl, methadone, and morphine. And what is the licensee requirements? If an eye surgeon is using only limited quantity of drugs, he is storing limited quantity, licensee is not required. But if the more quantity is required, then he can get his institution as a recognized medical institution for keeping this storage of these drugs. But the chemist and dealer needs a proper license. And then if you are having the license, we have to keep a record of the narcotic drugs in the form 3D or 3H and 3E for the details of the patient. Along with this, a copy of the prescription has to be kept for 2 years in case of use of narcotic drugs. And all the records have to be mandatory kept for 2 years. And the quantity is specified, how much quantity a registered medical practitioner can keep it without any license. Usually eye surgeon comes in that category only. And but if there is any unused medicine, that has to be returned to the store. And if there is any expired medicine, that has to be destroyed in presence of FDA officials. And empty vials are to be disposed of as per the SOP of the institutions. And there was a question whether an eye surgeon can use without a license. There is no license required for using the drug or for dispensing the patient. The license is required for storing or license is required for selling the medicines. If simply patient or anesthetist brings the medicine and it is given to the patient, only thing required is it should be recorded in the patient's file, so that if tomorrow somebody comes to verify whether this medicine was used by this patient or not, our file, IPD file stores. This is all about the protocols which are for these drugs. If there is anything else left, you can.
Thank you, Dr. Gupta. I think it was pretty comprehensive, but if there are any other of the panelists who would like to add something, most welcome. Please let me know if you'd like to add something to what Dr. Gupta has shared about high-risk drugs and narcotic and psychotropic substances. So the important thing is that if you're storing, you need a license. And if you're doing this particular, the use is going to be a recurrent use, then it is always better to have a license. If it's once in a while use, if it's rarely used, then maybe you can get it on the anesthetist license and it should not be stored. And the disposal of that particular vial has to be documented, and the drug, for whatever time it is there in your hospital, has to be kept in lock and key. I think that pretty much summarizes this particular topic. If there is no other panelists who would like to add something to this, I would like to go to Dr. Nutan in interest of time. Dr. Nutan, please tell me something about the use of off-label drugs. We use off-label drugs in ophthalmology, and how careful should we be and what should be the protocol for that?
Thank you, madam. First of all, real brainstorming session going on. Off-label drugs as such are quite commonly used even in ophthalmology, just as in pediatrics and gynecology, pregnant women and all. Use basically, I think, is more of local drops, intravitreals, and our antibiotics, which are fortified. Sometimes we use diluted drops. There are other few surgeries and medical devices which we may not talk just now because of the want of time. Now, off-label drug, whenever we are using, there are 2 or 3 things we should be clarifying, maybe during the process of our treatment discussion with the patient, so the patient doesn't feel that suddenly when they come to know that this was an off-label drug, they are not, feeling that something was hidden from us. So basically, it's good that we tell them that it is for their risk-benefit ratio should be to some extent just mentioned, that there is no other alternative of an on-label drug. There is off-label drug use of whatever you are actually going to prescribe as a standard procedure or as a preferred practice. Many other colleagues are using. And if we discuss this safety part along with why we are giving, there is no alternative. And we are not actually doing an experimental drug trial. It is a standard method of use. Then mostly there should not be any problem. As such, a consent is not really taken for an off-label drug use. But as I said, if it is an intravitreal or intracameral, there is a surgical consent which we are anyway taking, and to some extent it would cover us why we have used it. And if it is like a fortified drop or something, what we do at our place is, because I give label the dropper also, bottle also, with what has been done, how much concentration, when it should be discarded. Like if there is a change in color, we ask the patient to come. So that again makes it a little clear to the patient that we are not hiding any information. We are telling them that we need such a concentration, but it's not available. And we keep a copy like of that prescription and take a signature of the patient. So the relatives someday don't come that it was an off-label drug. It is usually possible and easy to use them. The problem comes is if there is some other side effect, may not be of the off-label drug, but then the patient or relative tend to push it on to the off-label drug because they know. And in general, probably if there is a general consent, which I think during COVID times we had started and we have continued, a COVID consent and a general consent, it becomes a sort of consent, or an implied consent also will do, that we are telling the patient that you will be, you are consenting for the history, treatment and medications and everything. So I think that should be enough for an off-label drug use.
Right. Thank you so much, Dr. Nutan. And there was some clarity which had to be made about consents, but I'm taking the liberty to go to Dr. Chandrasekar, because he's going to talk to us today about consents. And who better than Dr. Chandrasekar to tell us more about consents? Dr. Chandrasekar, so your questions about consents would be, what are the important aspects that are neglected about consent taking, and what about the retention and the destruction policy for consents? But before you answer this, would you like to tell us about the consent taking for off-label drugs, your experience and your protocols? Thank you so much. Please go ahead, Dr. Chandrasekar. You're muted, Dr. Chandrasekar. Can you please unmute yourself?
Sorry. Thank you so much, Dr. Zamina. So I don't think many of the institutions take a consent for off-label drugs. Otherwise, you're openly telling the patient it's an off-label drug, it can cause problems. Number one, and there is no role for a general consent when they enter, it is not even signed by the doctor. So actually, according to 5th edition, the general consent is generally done away with. Only the informed consents form a basis of all our procedures in the hospital. I should tell one statement. The patient or the man is the owner of his own body. That is the basis on which the consent forms have gained so much of importance. Many of the legal battles are lost in the court because of absence or improper consent forms. So just to tell what are the important aspects, all patient details, including the spelling, should be correct. Because there is one occasion which recently the MRD number or the UID was not clear. The spelling was wrong, and even if you've done everything else correctly, this can go against us. So it is very important, all patient details, proper problem, the diagnosis, the eye, everything should be proper. The procedure, and I'm sure all of us here will agree, you must talk about the benefits and risks and alternatives. It should be clear. It should be, see, there was a very huge argument about whether it has to be written. No, it is not possible. There was a national seminar on it. For common procedures, we can have a pre-printed form, but it should be bilingual. And many of the times, it may not be the language in which it is printed. Sometimes I'll get a Malayalam patient. We have only English and Tamil. We should make sure the person, another person who knows Malayalam explains in Malayalam, and the patient should write, it has been clearly explained to me in Malayalam, and then sign. So this is something very, very important. And second is this important aspect of the disease, benefits, risks, and alternative. Most important, it should be taken only by the doctor. The third one would be, the fourth one would be how many witnesses. We all have a problem of getting 2 witnesses, especially when we go for camps. When we do camp surgeries, you don't even get a attender. Only one fellow will come sometimes. But at least one, it should be not related to the hospital employee. At least one. Most important, it should be identifiable. Who is the person? What is the relationship? How to identify? Adults, only adults can give the consent unless they are unconscious or mentally retarded. For pediatric, it should be the legal representative. And lastly, everything should be documented with signature, name, date, and time, and seal. Even if one of the things is absent, it can go against us in the court of law. I'm sure all of you are aware there was a court where the patient side, they lost the case, but the Consumer Protection Forum said it has not been written. So they awarded 10 lakhs to the hospital, and there was a huge discussion on that. But we still will go, because more than 70 lakh surgeries you can't expect, and writing it will not be the similar kind of consent form unless it's a different new disease or a trauma. Everything else can be pre-printed. Regarding the second part, how long to retain, the retention policy, now we are moving into electronic medical records. At this point in time, whether we have EMR or physical records, we need to have a hard copy of the consent form. The retention policy as per the MCI is minimum 3 years from the last visit, and for pediatric patients, 3 years after they become an adult, if they have not come for 3 years. But once you document them as a medico-legal case or a case in the court of law, then it should be minimum 10 years if it doesn't go to court of law, or if it goes to court of law, probably lifetime till it is disposed by the Supreme Court. So this should be done. We have to maintain the consent form. It is the property of the patient because they have signed. So this is important to know. Some of the important aspects of consent form. In a multi-speciality eye hospital, we may have much more than 100 informed consents for procedures and surgical procedures. I hope that gives you an overview of the consents, Dr. Samina.
Yes, it does, definitely. Thank you so much, Dr. Chandrasekar. I think the last part of this panel discussion is about the communication needs in an eye care practice. Dr. Shailbala Patil unfortunately could not join us today. So the questions here are, and the panel is still with me, so I can take advantage of them. The question here is that, what are the communication needs in an eye care practice, and what is the need of documenting the communication? Anybody would like to answer from the panel? Please go ahead. Okay, in interest of time, I feel that communication errors are the most common errors in any hospital, leave alone eye hospitals, a common cause of medical errors. And about consent taking and a patient taking you to the court of law, I feel that all boils down to improper communication. There is a lovely book by Malcolm Gladwell where he says that in the first 3 minutes, the patient is in your room, he or she decides whether to trust the doctor or not. So please remember that the first 3 minutes, don't look at your mobile phone or talk to anybody, look at the patient, and the first 3 minutes are very important to develop the bond with your patient. So communication becomes very important at all aspects. Consent is a kind of a communication, a documented communication, of course, and consent taking should be taken in spirit and letter. So ideally, a doctor, a surgeon, or a part of the surgeon's team should be taking the consent, not a nurse or anybody, and the signature should be in place. Consent form should not be pre-signed. We have seen that hospitals have pre-signed consent forms available even before the procedure has been done. That really fails the kind of motive for taking consents. We have a lot of communication happening for an eye surgery, pre-operatively, post-operatively, pre-operatively about their, their health status, about their allergies. So all these things is a pre-operative checklist that needs to be documented. Pre-operatively about what kind of lens they want and whether they've understood. So we take a statement of acceptance and understanding from the patient. That the patient has understood that what kind of lens is going to get implanted, and this is the cost of the particular lens, and it is for one eye. so that the patient does not come and tell you it was for 2 eyes, right? So this kind of documentation of communication becomes very, very important. I think I have a talk on minimum standard documentation, and I will cover some part of that in that. Dr. Supriya wants to add something. Yes, Dr. Supriya.
Very nice. Just a small thing I wanted to add. Consent is very important, not only in OT procedures, sometimes very important OPD things also. Like even when we are dilating, we have to tell them that this will make their vision blurry. Otherwise, if we are not telling and we are not taking consent, another patient will worry, they are offended by that thing also. Also, if a patient is of foreign body or if there is any corneal ulcer, I think we should take consent in that also, because every time we tell them that we will make the corneal ulcer heal, but the opacity will be there and the vision will not improve. But again and again they come and ask why their vision is not improving, even if ulcer is healed. Also, while taking a foreign body, if there is an opacity or if there is any abrasion, again patient will say, you have taken out foreign body, but it's still. So we have to take a proper consent that in spite of removing foreign body, there will be some foreign body sensation till the abrasion is healed. Even in OPD procedures, consent very important. Obviously, in OTs, it's very important.
You're right, Dr. Supriya. Thank you for bringing that out. So I agree with her that there are OPD procedures also which require consent, like say foreign body removal or calagion excision, what we do it at OPD level. And though for dilatation, obviously we do not do that, becomes a part of the examination. And like what Dr. Chandrasekar said, that the 5th edition NABH now clearly says that a general consent is not required. It's an implied consent that a patient has come to your doorstep. It does mean that the patient wants that particular examination, and dilatation is a part of the examination. Now, I think what we would like to do, because in interest of time, this one last point what I would like to take about consent is that so many times there is a list of consent, but not all staff knows that we need to take a consent. So when you do the staff training, the staff should also be trained on what are the things in your hospital, in your organization, for which consent is taken, when it will be taken, who will be taking it, and all kinds of stuff. So please see that in your training calendar, you add a training on consents, which is very, very important. So thank you all very, very much for being a part of this panel. And I really enjoyed moderating this panel. Over to our beautiful MC, Shweta, over to you.
Thank you so much, ma'am. Thank you, panelists, Dr. Chandrasekar sir, Dr. Nutan sir, Dr.